Chapter 28, Mature Lymphoid Neoplasms. Mature lymphoid neoplasms represent a group of conditions that are divided into the category based on their disease, either a lymphoma or a leukemia. So lymphomas are malignant neoplasms that represent tumorous masses primarily in the organs involving lymph, such as lymph nodes, tonsils, spleen, and any kind of lymphoid tissue of the GI tract. Leukemias are a malignant neoplasm that primarily involves bone marrow and peripheral blood. These chronic types of lymphoid neoplasms are composed of mature lymphocytes and usually have a long, slow process of growth. Now, these conditions are not exactly clear-cut because there could have tissue involvement in leukemia, as well as lymphoma can also have bone marrow and peripheral involvement. The presence of these lymphoid neoplasms are thought to be a multi-step process that can involve either acquired, genetic, inherited, or environmental factors. So as acquired types of genetic factors, there are alterations seen in the oncogenes or tumor suppressor genes that have been associated with the development of mature lymphoid neoplasms. A lot of the damage from these genes are with programmed cell death and can be associated due to the BCL gene on chromosome 18 a lot of the times, and a lot of translocations. As for inherited genetic factors, some immunodeficiency syndromes, like the ones we discussed that caused lymphopenia, can be causes, as well as environmental factors. Now, these are certain types of infectious diseases or viruses, such as Epstein-Barr or H. pylori, that could be causative agents. So the diagnosis and classification of these mature types of leukemias involve a series of testing with clinical information, in addition to morphological appearance. And those ancillary studies include flow cytometry, chromosome analysis, as well as molecular analysis. So if we are talking about leukemia, morphological examination is performed on the peripheral blood and bone marrow, aspirate, and biopsy samples. With lymphoma, a diagnosis is rendered from a biopsy or a fine needle aspirate of the mass. And the cells represented here are more homogeneous than reactive because there's only an expansion of a single cell type. So once a diagnosis of lymphoid neoplasms have been made, classification is needed to guide therapy and provide prognostic information. So using the WHO scheme, it would classify it into a disease entity that has similar morphological, phenotypic, and genotypic features. So certain types of these diseases have a long course of infection and are often referred to as low-grade types of lymphomas. In contrast, there are some subtypes that are very clinically aggressive and kill the patient rapidly without treatment. These are referred to as a high-grade type of lymphoma. The WHO has classified the selected mature lymphoid neoplasms into leukemias and lymphomas that are non-Hodgkin's type and referred to as Hodgkin's type lymphomas. Those are separated based on the type of lymphocyte it's affected, so either B cells, T cells, and natural killer cells. Chronic lymphocytic leukemia or small lymphocytic lymphoma is a mature B-cell neoplasm that is of low grade, and it is characterized by peripheral blood lymphocytosis, but also can develop lymph node involvement. Patients can present with enlarged lymph nodes, but often develop into the blood and bone marrow type of conditions. They can be asymptomatic, but when they have symptoms, patients present with anemia, thrombocytopenia, and neutropenia. A diagnosis of CLL requires a sustained absolute lymphocytosis of greater than 5 × 10⁹ per liter with characteristic morphological and phenotypical findings. For immunophenotyping, you will see an expression of CD markers 23 and 200 in a weak expression of CD20. You will also see some genetic abnormality like trisomy 12 or deletions in certain parts of chromosomes. Now, in the peripheral picture of a patient with CLL, you see that the lymphocytes are small and appear mature with very scant cytoplasm. The nuclei are usually round, and the chromatin is regularly clumped. The neoplastic cells in CLL appear to be more fragile than normal lymphocytes and often burst upon smear preparation, producing smudge cells, and that's where you see those arrows. And it's very helpful to clinicians to report on these abnormally stained cells. Now, if we're doing a lymph node biopsy, it can reveal diffuse infiltrate of small mature lymphocytes, and these lymphocytes have a dense, regular clump chromatin and lack a nucleoli. At low power, they often present in aggregates of paler cells, which has a proliferation center, and these centers contain larger cells with abundant stained cytoplasm and prominent eosinophilic nucleoli. So here is a small lymphocytic lymphoma cross-section, which is showing a lymph node biopsy. And look at all the cells that have these nodules containing larger cells, which are paler, and those are the proliferation centers within the lymph node biopsy. B-cell prolymphocytic leukemia is very aggressive and rare, and it often doesn't respond to treatment. Sometimes it can be caused on its own, and rarely it can develop from an initial CLL. The patient usually has prominent enlarged spleen as well as very enlarged lymph nodes, and the patients usually have a marked absolute lymphocytosis above 300 × 10⁹ per liter, and here we see an anemia and thrombocytopenia are present. With this condition, you start to see a stronger impression or expression of CD20 as well as FMC7 with an absence of CD23. There are some chromosome abnormalities that have been thought of with this condition, but the short arm of chromosome 17 can often be deleted. So here the neoplastic cells have a characteristic appearance. They have a very large to moderate amount of pale basophilic cytoplasm, moderately condensed chromatin, and a single prominent nucleolus. Now, in this condition, prolymphocytes can take up more than 55% of the cells seen in the peripheral smear. Hairy cell leukemia is a rather uncommon B-cell neoplasm presenting in middle-aged individuals. Males have a 7-to-1 significantly higher incidence to female ratio. Patients usually have a massive spleen but lack any lymph node swelling. There may be extensive bone marrow involvement here. Therefore, patients usually present with a pancytopenia. The blood count is low because of neutropenia and monocytopenia, so patients are usually having an increased susceptibility to infection, especially Mycobacterium. Flow cytometry here is used to establish hairy cell leukemia, and you're seeing that the B cells are positive for CD19 and 20, 22, 25, 103, and 11. But with this type of condition, they have a separate cytochemical stain called TRAP, which is tartrate-resistant acid phosphatase. So these cells show a positivity with acid phosphatase after tartrate incubation. So on the left, you have a peripheral smear with these hairy cells. And these hairy cells are very characteristic because they have abundant pale cytoplasm. But their circumference cytoplasm has these projections, or they look like hair, hence why it's called hairy cell leukemia. They usually have an oval or convoluted nucleus and relatively fine chromatin. Now here we have on image B a bone marrow section, and we have replacement of these precursor cells by these small lymphocytes, and they kind of look like a fried egg appearance. Follicular lymphoma is the most common type of mature B-cell neoplasm in the United States, where patients are presenting with enlarged lymph nodes, and they are staged 1 through 3. Again, stage 3 having a lower survival rate. And at those advanced stages, you can start to see bone marrow involvement, but very little peripheral blood involvement. Now with phenotyping, you're going to confirm this phenotype with the CD10, and a lot of the times you can see a chromosome translocation T1418 that's involving that BCL2 gene overexpression. Mantle cell lymphoma patients usually present with a disseminated disease that involves multiple lymph node groups, such as the bone marrow, the spleen, liver, peripheral blood, and GI tract. Now, establishing the diagnosis definitely requires ancillary studies, so the following immunophenotype is characteristic: CD19 plus, CD5 positive, and FMC7 positive. This is a relatively aggressive lymphoma with a very poor prognosis, where patients usually live about 3 to 4 years. So here is some GI tract involvement, where you're seeing parts of the large intestine with these like polyp-looking things that are filled with those neoplastic cells. Now with these histologic sections, they're cross-sectioned and they can demonstrate a diffuse or nodular growth pattern. With the growth pattern that's nodular, it can be difficult to distinguish from a follicular lymphoma by morphology alone. The neoplastic infiltrate usually surrounds a germinal center called the Mantle zone pattern, and they're usually small to intermediate in size with round to slightly irregular nuclear outlines. Patients with extranodal marginal zone lymphoma of mucosal-associated lymph tissue usually present with diseases in these extranodal sites, such as involving the stomach, salivary gland, thyroid, or lung. And this could be preceding a chronic type of inflammatory disorder from gastric infection due to Helicobacter pylori or to some kind of autoimmune disease. This is a very slow process and usually presents negative for CD10 and CD5. So in this biopsy, we're seeing an infiltration of small to intermediate sized lymphocytes that are intimately associated with epithelial cells of the salivary ducts or gastric mucosa, and these structures are infiltrated by neoplastic lymphocytes. Now, this is composed predominantly of very small lymphocytes with round, cleaved nuclei that often have abundant pale staining cytoplasm. Diffuse large B-cell lymphoma is an aggressive type of disease composed of very large B lymphocytes. It can happen by itself or as a result of a transformation from a lower grade lymphoma, such as follicular or small cell lymphocytic leukemia or lymphoma. In this lymph node biopsy, you can see that there is infiltration of these large lymphoid cells that have a pale stain. They have irregular nuclear outlines as well as basophilic nucleoli. Burkitt lymphoma is another high-grade B-cell non-Hodgkin's lymphoma with a high incidence in Africa and represents about 1/3 of all pediatric lymphomas outside of Africa. Most adult cases occur in immunocompromised individuals, such as those affected by HIV. They can often affect extranodal sites, and they can involve the facial bones, jaw, as well, and kidney. Epstein-Barr has also been thought to play a role in the pathogenesis of Burkitt's lymphoma, but not as common as HIV. And this is very hard to distinguish between a diffuse large B-cell lymphoma, as their immunophenotyping pattern is similar. So the presence of TDT, or terminal deoxynucleotide transferase, allows this distinction. Now here in this cross-section of a biopsy in Burkitt's lymphoma, they usually reveal a diffuse infiltration of these neoplastic cells that look like a starry sky appearance, and the sky represents the blue nucleoli of these neoplastic lymphocytes, and the stars are usually the scattered pale staining tangible body macrophages. These cells are intermediate in size with nucleoli approximately the same size of those bodies, macrophages. Small nucleoli are present, and mitotic figures or apoptotic bodies are also present. Plasma cell neoplasms are considered to be a group of diseases composed of immunoglobulin secreting cells in the absence of neoplastic B lymphocytes. So they're a diverse set of disorders that rarely involve the lymph nodes and usually secrete this monoclonal immunoglobulin into the serum or the urine. And we're just going to focus on plasma cell myeloma or multiple myeloma. With plasma cell myeloma, you usually have a diffuse bone involvement, ranging from symptomatic or asymptomatic to aggressive, that can be present on radiological findings as seen in picture A. So symptomatic patients are characterized by an M protein spike in the urine or serum, clonal plasma cells in the bone marrow, whose symptoms are hypercalcemia, renal insufficiency, anemia, as well as bone lytic lesions, or CRAB. Patients often present with bone pain and multiple fractures because of this tumor infiltration. Cytogenetic studies have found over 90% of patients have some kind of chromosome abnormality, either hyperdiploid or non-hyperdiploid. with resulting chromosomes 3, 5, 7, 9, 11, 15, and 21. You're seeing a bone marrow cross-section and replacement of all of the hemopoietic precursor cells by an infiltration of those plasma cells. As well, in the peripheral blood, due to that high M protein, you're going to see rouleau, which is a stacking of those red cells in the presence of immune or increased immune globulin, like coins. Now let's talk about the T cell types of leukemia lymphomas. So T cell prolymphocytic leukemia is a rare disorder of adults and usually presents with marked lymphocytosis and splenomegaly. These patients often have an enlarged lymph node 2, skin lesions, as well as liver enlargement. The morphological appearance in this case are more variable than in the B cell. These cells have prominent nucleoli but can be medium or small in size and have convoluted nuclear outlines. The phenotype for this would be CD3, 2, 5, and 7 positive, and sometimes most cases are CD4 positive as well. They have cytogenetic abnormalities, but most frequently inversions of chromosome 14, as well as trisomy 8. And it's a very aggressive disorder with a mean survival of less than a year. Sézary syndrome is a neoplasm of mature T cells identified by a combination of red skin or erythroderma, and that's because those cells are infiltrated into the skin. You have generalized enlargement of your lymph nodes, as well as skin peripheral blood involvement as well. Now, Sézary cells are mature T helper cells and express CD3 and 4, and usually lack CD7. Are these neoplastic T cells. They have a very irregular, convoluted, more like cerebriform nuclear outline. Can have marked nuclear convolutions that are easily identified, but not all the time. They can look like the slide on the left. And they are abnormally large in size with regular, fine, distributed chromatin. Anaplastic large cell lymphoma is a rare case of large anaplastic cells that resemble Reed-Sternberg cells. Reed-Sternbergs are only seen in Hodgkin's type lymphomas. These cells are positive for CD30, but they lack CD15 expression and any evidence of an Epstein-Barr virus infection. A lot of cases have this translocation of the T25 chromosome that joins the nucleophosm and anaplastic large cell kinase or ALK genes. In this image, we have a cross-section of a lymph node biopsy, and you see these large cells that are infiltrating with an eosinophilic type of cytoplasm. Some cells are even multilobulated nuclei. Let's discuss the Hodgkin's type of lymphoma, which differs from the presentation as well as histologic appearance than non-Hodgkin's type lymphomas. In Hodgkin's lymphomas, you have large tumor cells that do not resemble a normal cell counterpart, and they're accompanied by many reactive cells. They have several different subtypes that differ in appearance of these large cells, the phenotype, as well as the nature of the reactive component. So the main types are lymphocyte predominant Hodgkin's and classic type of Hodgkin's lymphoma. And the classic type is further divided into nodular sclerosis, mixed cellularity, lymphocyte-rich, and lymphocyte-depleted types of Hodgkin's lymphomas. In this type of lymphocyte predominant type of Hodgkin lymphoma is composed of these numerous reactive small lymphocytes and rare tumor cells that grow into these loose nodular aggregates. And these tumor cells are characterized and can have a large multilobulated nucleus with delicate nuclear membranes, fine granular chromatin, and small indistinct nucleoli, which kind of makes it look like a popcorn cell. Now, the phenotype here is similar to that of B phenotypes, where you're seeing a CD45 positive in 20. So these reactive small lymphocytes surround these neoplastic cells, often include an unusual subset of CD57 positive cells. Now, the tumor cells in the classical type of Hodgkin's lymphoma have a very large, prominent eosinophilic nucleoli and coarse nuclear membranes. And one variant of the tumor cell found in these cases are the Reed-Sternberg cell, which has 2 or more nuclear lobes containing inclusion-like nucleoli and an area of a paranuclear clearing, imparting that it looks like an owl's eye appearance. These cells accompany the neoplastic cells, including the heterogeneous mixture of small lymphocytes. Sternberg cells are CD positive, can also be positive for CD15, and should be checked for Epstein-Barr virus as well. Now, the classical is further divided into sections and subtypes based on the sclerosis or fibrosis, as well as the type of tumor or variants that are there. Now, the nodular sclerosis subtype is characterized by these C-shaped bands of bifringent fibrous tissue, nodular aggregates and tumor cells variant with cytoplasm clearing and delicate multilobulated nucleoli.